So, we're just going to have a look at normal active ranges of motions. You do that for neck pain patients? Okay. And so we just start by doing a normal active range of motion assessment. So let's have a look at flexion. And let's have a look at extension. Okay, and then come back up again. What are you looking for when you do that? Sure. Okay, so you're looking for the quality of the range of motion, the smoothness of the range of motion, whether there's any pain on the range of motion.
Maybe associated movements. Is she?
Yeah,
You know,
she's looking for associated movement. What would that tell you? What did the associated movements tell you? And what does that tell you? Myogenic element? Yeah, okay. And if you see somebody who does, from extension or from flexion, they do, okay, they're over-recruiting, right?
Yeah.
They are wildly over-recruiting to get, return back to normal. And if you see something like this, what's the common things that you see with, like extension and return to neutral? Sorry? Yeah, so sometimes they leave with their chin, okay, as opposed to, what they should do. This is normal, to come down the chin and return to neutral there. So you start at the top and you uncurl your spine, okay? Whereas sometimes what you see is this. Okay? So they're using latissimus sternocleidomastoid to drag their occiput forward and then do that. Yeah. So in that situation, what do you think you would find myogenic? So we're really interested in what's going on in the deep neck flexors. And the head on neck flexors, so rectus capitis anterior lateralis, as opposed to longus coli. Okay. So that's important. The longus coli, which is the biggest of the deep neck flexors, is a controller of the neck, not a controller of the head. So we're quite interested in what's happening head on neck. Yeah? Okay. So you can sort of see, I'm sorry, what's your name? Maddie. Very nice to meet you. So let's just extend again. And you can see something fairly typical going on there. What can you see? Comes back up again. Yeah, it's hinging right through there. Okay? So that's not unusual.
You see that in most people.
You see that in most people, but what does it indicate?
Poor segmental control. Yeah.
Sorry?
Poor segmental control.
Poor segmental control, possibly. What else could it?
Stiffness lower down.
Yeah, so possible areas of stiffness lower down, higher up. I mean, the thing is, of course, is that the cervicothoracic vertebrae is naturally stiffer anyway. Okay? So you expect to see more movement there, but if this is very stiff, then this becomes very mobile. Okay? And so that is a pattern that you will see again and again and again and again and again. Okay? Let's not consider it normal. Okay? It is usual in your neck pain population, but it is not normal movement. Okay? And so you're right. That might indicate that you need to go somewhere else and look at what else is happening. As part of the problem. So you may have to sort of think about what else is happening here. So it's good to look at the quality of the movement. Okay? And then I'm going to just stand up for a minute. Let's have a look at the side flexions. Okay, and what are you looking for here?
Gains of range, quality,
Yeah.
contractual muscle,
Yeah.
muscle activity.
Shoulder
Itchy,
elevation,
Yeah. So you're looking at the same kind of compensatory strategies. The compensatory strategies can be a little bit different, but you should be able to side flex without moving too much. Okay? You should be able to do that. Okay? But of course, if you've got tightness, then you will need to do this in order to get more range of motion. Okay. So side flexions, and you're looking at the quality of the movement. So it's good to look at it from behind as well. And you're looking at sort of a fluid curve. Okay. So side flex again.
either way.
Either way, yeah. Good. And come back up again. And then the other way. Okay. So she's got more range of motion that way than she has this way. The more range of motion to the right than you have to the left. Can you feel that?
I always crunch my neck to the right.
Sorry?
I always keep my neck a good crunch to the right.
Do you?
Yeah.
Okay. Perhaps you should crunch it to the left.
Well,
Can you see that? You can probably see that, can't you? So just side flex to the right. There she goes. And then come up again and over to the left. And she's just not quite there, is she? So there's a question of, is that limited by muscular structures? Is that limited by artificial structures? What can we do with that? How can we,
Fantastic.
The right shoulder.
excuse me? Just in little go. I was hard work. Okay, and then over you go to the right. Sorry, over to the left. Okay, and then come back up again. Over you go to the left again. Okay, back up again. And then go everything. That's it, and then over you go. Yes, you get much more range.
Yeah.
Now that's not unusual. You'd expect to see that. If you do that on yourselves, you'll see that that is true. And then there is a question of, well, what is the difference between left and right, and what is the difference between what might be considered to be relatively normal. Okay. So in this situation, you're kind of thinking, well, there is something unbalanced and asymmetrical about that. A certain amount of asymmetry is fine, but there's a question of whether that adds up with pathology. Do you have neck pain? I didn't ask you that.
no.
Headaches?
Occasionally, but not.
Where do you get your occasional stuff? Okay, both sides.
It's very rare, so I'm not really remember.
Okay.
No, sorry.
Patient.
You're just as bad as your patients.
I don't get a regularly.
Okay, fair enough. Well, we won't worry about it too much, okay. But what does that tell you when you see something like that? About arthogenic versus myogenic?
Good differentiation.
Yeah.
It's good differentiation for arthogenic versus myogenic. Okay? So I mean, you'll find that a lot of headache patients will respond really well to this kind of thing, because they do get a lot of tight muscles. And so the question when you sort of see active range of motion stiffness is, to what extent is that arthogenic and to what extent is it myogenic? And if you see something like this and you sort of see good quality range of motion after you release upper muscle sort of stuff, you're thinking, well, it's less likely that I'm going to find positive arthogenic signs. Yeah? And so that's important to kind of understand. So do you do that kind of symptom modification? Yeah, yes.
Sometimes the patient has referred symptoms and to do elevation.
Yeah.
Sometimes it also might increase the range and decrease symptoms.
Yes.
So it's
Yeah. So there.
differentiate.
Yeah. Well, you can differentiate. Okay. So you're right. Releasing that is not simply myogenic. It could be neurogenic. And relaxing the brachial plexus too. Okay. Okay. Right. Over you go to the left now. Come back up again. Okay. So just relax onto there. Over you go to the left. Okay, and come back up again. Move your hands. Over you go to the left. Okay. Over you go to the left. And come back up again. Straighten your legs out in front of you, like a slug test.
It's not a strong point.
Okay. And over you go to the left. And come back up again. How does that feel? Does that feel better? Does that feel worse to you?
It feels worse than my back.
Okay. Legs up front. Over you go. Okay. Right.
Can
So-
I just ask?
Yeah.
You put your hand on her head, is that because she was falling forward? Yeah.
She was trying to bow out of it.
Yeah.
Okay. She was trying
Thought so.
Yeah, she was trying to find an easier way of doing it. And that's completely normal. Just
Yeah,
finding-
yeah.
I mean, that's what compensatory movement is, finding the easiest way to do things. But of course, what I want to do is help her to repeat the movement, not let her bow out of it. Okay. That's why I put my hand on her head.
Each time I relax my hand back down, it felt like it was going in.
Yeah.
So gradually felt like it was getting easier.
Yeah.
So not.
Yeah, so repeating movements is
Yeah,
actually,
it's actually,
it's actually good.
I don't know if I was getting my range, but it felt like my
Yeah. If I see that with a patient, because you do see that with patients where they kind of go, you know, you subsequent time, you're doing assessment, and as you go on, movements are getting easier and changing. I would bring that up and I would sort of say, you know, this movement looks like it's getting easier. How does that feel to you? Why do I do that?
Emphasize movement.
Emphasize, I'm trying to emphasize that moving is okay. Yeah. So you're constantly trying to win that battle. Yeah. Okay, so that's a bit of side flexion. Let's have a look at rotation. Okay, what are the compensatory movements that you'll sort of see there? And then around to the right. Can you see that there?
Side flexion.
You see it here, can you? Side flexion. Okay. And then come back to the centre. She's doing it that way. And then, not so bad that side. Okay, go to the right. But it's very obvious going to the right. So she's doing something there. Okay. You're side flexing. Okay. So you're rotating and then you're. So what we can do is we can guide that. Okay? We can just simply guide that. Okay. Now let's go around to the right. That's not lateral side flex. But she can do it. So what's that mean? I mean, in terms of arthrogenic, she can go. Okay, there's more range than she's letting on, but that the movement pattern, she's developed a movement pattern, which is not sort of rotation, but more sort of side flexion strategy. So she's doing something antalgic, and then to the left again. Okay, and all I'm doing is guiding that. Okay, so she can go quite far. Okay. But you know, the other thing that we can do is we can have a look at that neurally as well. Okay, so just turn your head to the right. Okay, so that's side flexion.
Yeah,
Okay.
I can see it
And then
really
come back
quite
one.
obvious now.
Okay, turn your head to the right. Okay, fine. And then come back to the centre. And turn your head to the right. I'm not going to change it too much, I don't think.
She sways away.
Hmm?
She sways away.
Well, she's memorising.
Yeah, she's overly trolling.
Yeah? Okay. So, that kind of manoeuvre is actually really good. Okay? Median nerve is a good sort of test. I mean, we'll come back to that for the neck, but I mean, you can sort of do an armor bias instead. This is not for the average cervical spine particularly, but you can do an armor bias and do the same thing. Okay? Yeah, and you can do, yeah. And if you want to, you can do, you have to be careful to keep the shoulder still. Okay, you can do a bit of a radial bias too and see what that does. Okay, so generally for the neck, those are quite a good screen. Median nerve is a good screen. Okay, but you can bias radial if you think it's more radial. You can bias on left, and that's just quite good strategies. The other thing I would do is alter posture. Okay, so I just let them sit as they want to, alter posture, and see whether that changes anything. Okay, that's another good simple modification procedure. And depending on what else you see, I mean, there's a variety of things you can modify. I mean, if people are very protracted, what you can do is you can control that protraction. So you can control the protraction and then repeat movements. Okay, so there's a variety of things that you can attempt to control in order to sort of see if that changes what's happening with the neck. Okay. We can do more focused upper cervical, and that's a bit of a general sort of cervical screen, and so you can sort of see whether there's specific issues and problems. Okay? But you can do something that's a bit more upper cervical as well. So let's just think about extension. Hang on. So we can do upper cervical extension. Okay? So there's the end of her upper cervical extension. She can extend a lot further, but that's the rest of the neck. Okay? Is that okay for you? Yeah. Okay.
So could you protract that external?
No, I just took the head back.
Right,
Okay? But what I'm doing is control. I'm not pushing it, I'm just controlling it.
okay.
Okay? So let's just tip the head back. There. And that's the end. Can you feel that's the end of that? Now overpressure is not that, okay? Overpressure is this, okay? Lift the chin, bring the occiput in, okay? So you have to control that, okay? We can do upper cervical flexion, so just tuck the chin in, okay? And we can do upper cervical flexion of pressures. Side flex you. So we're not going, whoa, okay, we're not doing the whole neck. We're now just side flexing the head from the neck, okay? Can you feel that's the end? Okay, and then I can overpress that. So I'm not overpressing there. What I'm trying to do is just a little bit of extra. So I'm doing like that, okay? And then the same with rotation. It's a bit hard to control. Rotation, most of the rotation occurs where? How much rotation occurs at C1, C2? 50% of the overall rotation of the neck. It's about 30 to 40 degrees of rotation at that one kind of level. Okay. So, you may not be able to see very well. Okay. So, what we're going to do, focus on C1, 2. Very little happens at C1. There's like a millimeter of rotational degree of rotation movement. It's very hard to control. So I'm going to get you to just flat forward. Arch down. Okay. I'm sort of on C2. I'm going to just let the chin come forward at the C1, 2 and C0, 1 are kind of in a neutral position. So I'm not forcing anything. I'm not applying lots of pressure on there, am I? No, that's fine. Okay, I can to overpress flexion. But what I'm then interested in is what is rotation doing and what is rotation doing. This is very informative on headache patients. This is very, very informative. Okay? Good way of isolating. Okay? So what I'm doing with this hand is I'm just finding the spinous process as C2 and I'm just trying to get them on the entire arch at C2. Okay? So I'm there. I let the chin come up so that the soft tissues above are relatively relaxed. I'm not digging, okay? You don't want to dig and nip. You can really squeeze, and that can be uncomfortable and painful. Is that uncomfortable and painful? Okay? You don't want to do that, because if I do that, that's it.
So are you limiting
There's
rotation?
rotation, okay? If I just relax, it gets a bit more.
What do you mean relax, sorry?
Rather than doing, let me show you. Okay. So rather than doing, give me a hand. Rather than doing this and trying to fix and hold, I'm just doing that. I'm not applying lots of pressure. And then when I move, what I'm doing is feeling for movement. So I'm not trying to fix. I stop and I feel C2 trying to move. Okay. So let's get your flex forward again.
What would happen if your chin was right down the bottom? You said you had to extend into more extension a little bit.
Yeah, bring her up a little bit
So
there.
what do you want to do that?
So I'm just putting the upper cervical spine into a more neutral position. Right. I can extend her into a forward head poke, okay, which is where people want to be, okay. But what I'm trying to do is put her in a neutral position for her head, so that you can get maximal rotation at C1 too.
Yeah, because if you flex too much, you wouldn't get the rotation. You wouldn't be able to see enough rotation. It would fix it too much.
Yes.
Yeah.
If you flex too, if you're just flexing, it's very hard to rotate.
Yeah.
So if we flex and flex and flex, fix C2, and go, let's see what you can do. Actually, guys, you do it too bad. Okay?
So if you did this test as a normal neck position, then would it just you'd be getting too much? You won't be able to resist the lower cervical rotation.
Well, you can. I mean, you can get on the, you can get on here and you can try and fix C2. It's not hard to fix it.
So why you bring them into flexion and why bring them
Take up soft tissue.
our
Because in this position, what you do is you take up the extensors of the neck, okay, which will help to fix the lower, middle and lower parts of the cervical spine.
Right.
That'll fix that. I then find C2. I don't let that come off. What I do is just let the chin come up and relax the upper portions. So hopefully this is a bit more locked. I can control it better. I can feel the movement better. And then she can get around to there, and then I can feel C2 moving.
And it's locked because of muscle stiffness.
Muscle tightness.
Yeah, there's nothing off, nothing nothing to do with the joints, is it, by taking them into flexion?
Yeah, you're also taking because you're taking up one movement, you get less coupled movement or combined movements. Because you take up flexion, you don't get so much rotation.
If you're looking for the restriction to the upper cervical spine,
That's very right.
sorry.
Would you do it from line as well?
You can do it from line. I suppose you could do it from line. I mean, we're going to do other forms of examination in line. I would tend to do this in system.
I mean, from line sometimes soft tissue will be more relaxed and then you can actually shape the movement on that.
Yeah, I mean, you can try it and see whether you can control it. I mean,
I'm just asking,
yeah.
I haven't done it before, but I
Yeah.
understand.
I mean, you can try it. I mean, the point is, you can do whatever you can control. That's the point. You can do whatever you can control. I guess something like this is quite functional. It's quite a functional position. And we are going to go on and do more specific examination of arctogenic motion and stuff like that when the application is done. So when we come to do pivots and palums, in theory that's a more specific examination.
Because on a couple of occasions before, I had irritability was quite high.
Yeah.
That's why it was really difficult for me to do any examination from setting.
Well, yeah.
So,
Okay. So you may find that there is a very
That's
limited
why, yeah.
examination. Yeah.
so you would like that or you couldn't do anything?
No, I would still tend to do an examination like this. And the point of doing an examination like this is that it's functional and people have to be upright. In their daily lives they have to be upright. And they either are standing or they are sitting. And if, most patients have most problems in sitting with their necks. If they had a problem in standing, I'd probably do the examination in standing and get some big rocks to start on themselves. Yeah. Or I'd get them to kneel. And then examine them in an upright position with a kneel or something like that. Maybe that's possible. But yes, I would examine them sitting. And this is my preferred place because it's what I think I can control best. And in the end, it's all about controlling things.
Would you offer a few dangling?
Sorry?
Would you have a few dangling or fixes before?
I was going to ask them to put better on. So, I'm quite clear.
You can't talk about that way. It's quite comfortable.
Would you follow us up though in the exam for that?
You bet I will.
One of us
You're a marked one. I don't even believe me in front of an entire
That's very assuring to be all people in the life.
You will be. Oh, you will be.
Want.
Well, you now all know that it's not the right thing to do. Joe's made that quite perfectly. Okay. No, and to be honest, it's probably easier to be in as well without you. Yeah. But I mean, for a small person, I would probably have a bed a little bit higher because I'm trying to be comfortable. I want my patient to be comfortable, but if I'm not comfortable, then I can't examine. If you're uncomfortable, and if you are yourself personally uncomfortable physician, you don't have very good feel with your hands. So the more comfortable you can be, and obviously this is great because I can get my legs up here, I can put myself in a really balanced position where I can then feel properly in my hands. So what have we done? We've done flexion. Oh, we've done rotation. Yeah. So we've done flexion, extension. We've done rotations.
Side flexion just
Side flexion was that. Yeah. Rotation. So we can do C01, we can do C23. You can try and do that. So this time what I'll do is I'll take up C01 and 2 into upper flexion. I'll drop down from C2 onto C3 and try and fix C3. Okay? And then from there, we'll look at rotation. Okay. You might have to do that to control it. She's got a very nice rotation. And what you'll feel is when, I don't know if you can sort of see that on my thumb here, but when I rotate round to the right, you see my thumb beginning to move. Okay? Now you might think that that's soft tissue there, but what I can feel is the pressure on that part there. Okay? Okay, so I'm around the arch of C2. So I can take my thumb away, okay, and I can still feel the pressure just building up underneath my thumb.
Do you think maybe all the movements coming from C1 to C2?
That's what I'm trying to achieve. I'm
No,
probably
actually,
not
that
perfect
would be
in that, okay? But what I'm trying to do is bias the movement to C2. Okay? It's a biasing, it's not perfection. Okay? So I do my best to eliminate what's going on below, I do my best to eliminate what's going on above, and then I try to see what's going on in the area I'm trying to move.
Can you do it neutral rather than flexion?
Yeah, I mean, you probably could do it, but then it's very difficult to then kind of go, because from here, you can release C1, C2, and then you can go, well, I'm trying to release C3 as well. So I've also got C1 rotation coming in. What I'll get is much more movement. I'll just get C1, C2, and C3.
So when you did that,
I'll just get much more movement.
when you did that the first time, I thought it looked like quite a lot of movement still, if it was just about level.
For C23?
Yeah.
How much rotation do you get at C23?
I don't know.
Yeah, quite a lot. Okay. So you put, I've got some figures, and they're quite old figures, but nothing's changed. People haven't changed much. But it's probably about 10 degrees. You know, when you sort of think that the greatest movement comes from the highest levels, you get about sort of 30 to 40 degrees from C1-2, minimal from C0-1. You then get the next most from C2-3. And then as you go further and further down, you get less and less and
You
less.
get more than 10 degrees there, though, weren't you?
Down here?
No, when you were doing the C2-3.
Yeah, I told you it's not perfect.
Need more practice then, maybe.
So,
Just do that again, what you did.
what did I do?
C2, 3.
C2-3, yeah. Okay. So, upper cervical flexion, okay? Not, they won't retract, okay? It's just upper cervical flexion. 2, 3, the arch is C3, okay? And then from there, I'm going to rotate, left, and rotate.
So Sionnadh, you're not fixing C3, you just...
I could do that, but it's uncomfortable,
Yeah.
okay? So what I do is I'm just guiding. I'm quite firm. I'll use my hand, I'll show you when I come round, okay? And I'll let you feel it.
So just feeling the spine process just as it starts moving.
Yeah, I feel, what I'm feeling for is resistance, okay? So when I get to there, okay, this next one moved really well. Okay, when I get to there, what I'm doing is I'm feeling there, I'm feeling the arch of C2, I'm feeling the arch of C3 beginning to just move, and I can feel there's a resistance there. Can you feel that resistance? Yeah? Okay. Just you put your thumb on top of my thumb there. Yeah. On my knuckle pads. Okay. Don't press too hard. Nice and light, so you can feel. Okay, that's it. Can you feel my thumb vibrating? Oscillating?
A little bit.
Yeah? Right? That's what I'm feeling for. I'm feeling for that. The C3 arc oscillating against my thumb.
When are you going to do the way? You're not changing sides, are you? You're just doing whole
No, but I probably would change sides.
Would you?
Yes.
Because you're going to feel it more.
Yeah, you're feeling more accurate. Absolutely. Stop talking, go do, and you can, we'll feel it as we go. Yeah? Right, shall we make a start?
Okay.
Do you know what you're all sitting down for? Go straight into it. So we're going to continue with pivons. We're going to move from C01 to C12 and C23.
Cold. He's comfortable to relax.
Yeah. So this is with C12 and C23, you can do this in a variety of positions. So you can actually have the head over the pillow. When we do the spiral spine, we could spine days, which is the next day block. We'll do pivons again for the rest of the spine. We'll be over the edge of the bed. But since we're on the axis of our spine and we've been doing Sionnadh, we'll just keep the patient in the same place. Okay. So I think I said already that you need to move from transverse process backwards and laterally. Okay. So what you basically are going to do is drop off the back of the occiput. Okay. So from here, where the occiput is, you're just basically going to drop off the occiput on either side of the spinous process.
What's this one you're doing, Sean?
So you want to. Okay. And if you do that yourselves, you can just feel yourself behind, just drop off the occiput. What you should do is drop it, and if you need to, you might just need to kind of just put your head back a little bit so you're not working your extensors. But so you can relax your extensors, and what you'll find is that your fingers just drop into a hole. And right in the base of that hole is C1, 2. Okay? And so, what you're looking for is that space there. Okay? So you can sort of see there's a very broad sort of joint space. And that's what the hole is that you're dropping into. So you're dropping into there. So you should be quite central, but not completely central, but you're going to be in that space there. I usually use these two fingers, just because it's a very broad space to fall into. And then the pivums I work all the way down with both fingers. And basically what I'm trying to do is get on there, there, so I'm on the articular pillar. Okay, so it's actually very central. Yeah? Okay. So you start with C01 and it's very broad, you're way up here, and then after that you're actually very close to the spinous process, just sort of following all the way down. Okay. So from here, I'll just drop off the occiput, sort of creep off the occiput, and when I do that, I just sort of slide straight into the space that I want. Okay? And I only do one side at a time. Okay? So do the same thing, side flexion, creep down a level, keep down a level. Okay? So what you'll sort of see is that the further down we go, I follow his hand. Okay? So I don't just go like that and get further from this hand. I creep down with this hand. So this side is on a spinous space, in the articular pillar between this sort of, on the spinous sort of space. So C1, 2, I'm in that space, and this hand can be on the occiput on this side. Okay? And to create side flexion, what I'm trying to do is pivot around these fingertips. Okay? So that's the pivot point. Okay? If I do this, can you see that I'm not actually side flexing the level that I want? I'm side flexing the neck, but it's much lower. Okay, that's what you have to be careful of. So you're sort of side flexing the head and the neck. Okay, so you're side flexing C1 over C2, and then you keep down to C2, 3. You're trying to side flex C2 over C3. Okay.
How much pressure you get doing with that hand? What do you
How much
stick-
pressure am I
you
doing
sort
with
of-
that hand?
you-
With that hand.
Until you feel a movement,
What?
of course, isn't it?
Fixing.
It's
Your,
like with
your fingers or your hand?
fingers.
With fingers, it's just proprioceptive. It's
So you
not,
just
it's not
feel it
firm.
until you feel the movement and then you move it down.
Yeah. So bearing in mind that if you do this technique and you're sort of falling all the way down, you're only going to side flex 5 or 6 degrees each level, 5 or 6 degrees. And that might look like 10 degrees on the surface, okay? But the actual joint itself only has about 5 or 6 degrees of sort of side flexion available to it. So if you're sort of side flexing sort of fairly segmentally, and now you sort of see I've come on this side, I've come underneath the ear, so I'm a bit more onto the neck. And now you see, when I'm up here, you see that I'm trying to side flex the chin. I'm taking the chin over, okay? The further I come down here, I'm sort of pivoting round the chin. Does that make sense? The key thing that I'm thinking about is moving the joint that I'm on. And that's what you've got to be really concerned about. If you're moving other structures, you won't feel anything under your fingers. So if you end up moving the cervicothoracic junction, you are not going to feel anything under your fingers, and nor should you. Okay? So the key thing is, from here, you're thinking about side flexing the head on the atlas, and then here, you're thinking about side flexing the atlas on the axis, And then here, you're thinking about side flexing the axis on C3. Does that make sense? From that side, it looks like this. Okay? So I'm not moving very much, but it's basically the same principle of side flexion. But what happens is where my focus, my drive changes to just allow me to create a different movement in a different place. Which is the same movement but a different place. The rotation is the same. At that point. Okay? So you can use the head. Okay? But of course here, what you'll find is you've got a lot of movement at C12, so you can actually rotate quite a lot. Now where I was here, and I was C01, rotating through neutral, into C12 with a lot of movement, and then rotating from neutral through 20 or 30 degrees. And then down a level, and I'm just rotating beyond that. Okay? Which is not brilliant. You can't just keep doing that all the way down the neck. But for the top 3 segments, you can just about get away with that. So from this side, it looks like this. Okay. You might need to just create a bit more space. Just lift your head a little bit, and then down again. So the occiput, does that feel like it's quite reasonably well supported? Okay. You can just create yourself a little bit more space by just having a bit more space. This is why I like working with towels, just to give my hands a bit more space.
Do you not take it to the end of the range and then moving down, or just checking each one?
You're checking out, you're trying to do segmental movement. Okay? But in this position, what's easier in terms of rotation is to just keep moving the neck around. But that doesn't work when you get to lower levels. It's actually very hard to control. Because the upper cervical spine, the total sort of combined movement in one direction is probably about 35, 40 degrees, something like that in total. You can cope with that. Once you get further on, it's actually very hard to cope with. It's very hard to cope with techniques of that sort of position. But for C01, C12, C23, so for an upper cervical spine examination, you get away with that. Yep. But I'll show you a different way of doing that when we do the cervical day. So if we just concentrate on the cervical spine, I would do that technique in a slightly different way. You happy to have a go at that? Rotation, side flexion of, yep. Don't forget to have another go at C01. Okay, so I'm going to do this. I normally just usually use rotation and side flexion pivotings for the cervical spine, and for the rest of the cervical spine too. In theory, you can do flexion extension pivotings, but in actual fact, when you think about what flexion extension is, and you think about what you're doing with side flexion and rotation pivotings, and you think about what the glide of the joints are, then side flexion and rotation gives you enough, should give you enough information. And so flexion extension is actually very difficult to control, and I don't think it provides you with too much extra information. So side flexion rotation is actually probably the most informative things that you can do. Okay? And if you've got somebody who's got an extension problem, what you're interested in is, how it's side flexing left, how it's side flexing right. So you can locate the side of the problem. Does that make sense? Mm-hmm. And in the end, it's the same motion that's occurring at the joints. So, although you can do flexion extension, I'm not going to show you that because there's plenty of other things that you can do. So the other thing that you might want to consider is neural structures. What neural structures are you familiar with? Don't you answer my question? Okay. What neural structures are you familiar with that might be a source of symptoms? Yeah, well, there's the fifth cranial nerve, and because it sort of feeds directly into the spinal cord. Yeah. So that peripheral nerve, that peripheral facial nerve, the peripheral cranial nerve, is something to be of interest in. Anything else? Cervical nerve roots. So C1, C2, C3 nerve roots are of interest. peripheral nerves. Anything else? What about the central nervous system? It's a mechanical structure.
Nucleus.
Okay. The cervical trigeminal nucleus is a nucleus that exists within the spinal cord. So the mechanical structures that we're specifically interested in are the meninges.
Right,
Okay? The meninges attach to the foramen magnum. Yeah? And the meninges are themselves innervated, like any other connective tissue, and can be a source of pain. Okay? So we're quite interested normally in things like slump, are we? And of course when you do things like slump, full body slump, it has an impact on the meninges as it travels through the foramen magnum. Yeah? So one of the things that we're going to look at is we're going to look at, well, we call it a dural neural tissue provocation test. So we're going to have a little look at that. Okay? And we've already done sort of movements of the cervical spine, okay, flexion, extension, rotation. So we'll have a reasonably good understanding of what that's looking like. And we already did a sensitizer, didn't we?
Yeah.
On Maddie, that's right. So we looked at slump a bit, and we looked at adding on that. So that's fairly global. So you can do things like that to a bit of a screen. But what we can do is we can do something a little bit more specific. Okay. So the dural structures have an attachment to C2, so the arch of C2, and they attach to the foramen magnum. So posteriorly, if what we do is we flex the upper cervical spine, that will be elongating the dural structures. You happy with that concept?
Yep.
Okay. So what I can do is actually, I think I'm going to spin your head around. Is that okay? To the other end of the bed. Just because that gets in the way for me. How's that looking? Oh, that'll do. Okay. So what I'm going to do is I'm going to basically try and take the occiput away from the C2 spinous process. So I'm going to use this hand as a bridge for C2 to sit on. And then I'm going to control the head with my hand and my shoulder. And then I'm going to produce upper cervical flexion. Okay. So find the C2 spinous process. Oh, you think Gary's neck is good. Okay, C2. Wow, there you go. And what I'm going to do is I'm just going to give the C2 a bridge to sit on. So I'm just creating a bridge.
So the C2 is sitting on
C2
finger.
is sitting on my
Index finger.
thrusting knuckle of my index finger. So sitting on there. Okay, so there's C2. I'm just sort of supporting it. I'm not trying to push too hard into it, I'm just supporting it. I've got my hand under the occiput, because I'm going to want to do that. Yeah. And I'm going to use my shoulder here to pin him down in the bed. Because when you try and do that, the temptation is to lift. It's hard not to. So I'm just going to use my shoulder there to just pin him down in the bed. And I'm going to do that. Okay, that feels a little bit restricted. How can I sensitize that? Because that could be arthrogenic, it could be myogenic, it could be neurogenic. Yeah, I could do straight leg raise, couldn't I? Okay. Do you want to, James, grab his legs? You can have one at a time.
And in particular one first.
Yeah? Yeah, I'm ready. Just lift his leg.
Just stick a minute.
Keep going.
How high does he go?
Fine, hold that there. Okay, can you feel your head pushing into my hand? Okay. And what you should see now is a difference.
Yeah,
Okay?
a lot, isn't it?
Yeah?
Oh, yeah.
Put his leg down. Can you feel your head relaxing?
Wow.
Okay? Right? Okay? And then just take his arm and put it into median nerve sort of position.
Can I just ask you, what would be considered,
Ah.
you know,
but that's I don't like some position.
Okay, thank
But is there a normal amount and a pathological amount? In other words, would it, so it would normally be different anyway.
Yeah, that's enough. I can feel that. Can you feel your head pressing into my hand?
Yeah.
Okay. But what I can feel immediately is I can feel that. I can feel them sort of retracting.
Right.
Yeah. So yeah, just add a little bit. So yeah, don't roll the shoulder up into rotation. Just extend his elbow in that position. Yeah, keep going. Okay, so I can feel that increasing. Can you feel that increasing?
Not too much.
Okay. Hold that there. Okay, and then just bring his elbow back in and his hand back in.
Yeah.
Okay.
Mhm.
Okay, that's fine. So you're right. You will feel differences, you know, for yourself. You should be able to sensitize your nervous system, even in healthies. Okay. So what we're looking for is differences side to side. Okay, and things that add up with the rest of the picture that you're putting together. What you're collecting is pieces of a jigsaw puzzle. Okay, and what you want is pieces that all fit together to give you an overall impression of what the problem is. Does that make sense? If you kind of get pieces and you kind of go, shit, well, how does that piece fit into that piece? Then you've kind of got conflicting things going on, and you know, there's some work to be done to make sense of some of that. Okay? Does that make sense? So yeah, it's quite normal for that to occur. This test also, what stability test am I approximating when I do this? Have you looked at stability? Not the sharp person. No. No. I know what you really want, please. Tectorial membrane. Okay. So what's the tectorial membrane? It's a continuation of the three. It's a continuation of the posterior longitudinal ligament. So it continues on from C2 up to the foramen magnum. So if you just traction the neck, that'll give you an indication of the stability of C1, C2 and C0 as a combined unit. Okay. I'll show you the others after this one. Okay. So for the upper cervical spine, dural matter, you're looking at creating flexion. For the tectorial membrane, you're looking at just traction. See the difference?
Mm-hmm.
Versus that. Yeah. Okay? So they're very similar. Okay? And you're probably able to sensitize that as well. Okay, we're going to have a go at both of those. Okay. We're going to do some of the other ligament tests. So you've already kind of run through all the ligaments, sort of, in a very knowledgeable way. So we've had a look at the tectorial membrane. What are the other ligaments? Sorry? Alar ligaments. Where do the alar ligaments attach to and from? Yeah? Sorry? Yeah, somebody needs to look at their what? Yeah. They attach from where, sorry? Yeah, they attach from the top of the dens. So if I am C2, okay, the body of C2 is on the floor, and I am the dens, then it does that.
Yeah.
Okay? And it attaches to what? Foramen magnum. Yeah, attaches to the foramen magnum. Okay? So it goes through it goes through the atlas. Okay? Through the atlas and attaches onto the foramen magnum. So how would I test those for stability? Lateral flexion. Okay? So you can do lateral flexion on a fixed C2. Okay? I'm going to do that in a second. What's the other ligaments that confer stability to the upper cervical transverse? Transverse ligaments. Actually, it's a cruciform ligament, but the transverse ligament is a horizontal portion. What does it do? Okay, so if I'm the dens and I'm sitting against C1, I've got transverse ligament behind my head, behind there, and attached onto the C1. Okay? So it wraps around my head and holds me on there. But I've also got cruciform bits. Okay, so I've got a bit that goes that way and a bit that goes down. Okay, attaches to C2 and the frame of magnum at C1. I can't remember quite which. Okay, so it's a cruciform shape. We can sort of test the transverse components of that. How do we test the transverse components of that? So, okay, I've got the transverse ligament behind here. I've got the atlas there. Is this good? Yeah. Okay, so that's what it looks like roughly. Okay, sort of.
Are you a fly?
Yeah, you can just kind of imagine it. Okay. Yeah.
So it's not sharp.
Okay. So there's two things you can do. Okay. So basically, what you want to do is test the wiggle room of the end inside the transverse ligament and the atlas. Okay. And what you don't want is a lot of that going away from the atlas. You don't want the transverse ligament to be slack, and you're doing that and pushing away from the atlas. Okay. So there's two things that you can do. The first and the safest thing to do, particularly if you think of somebody who has got sort of maybe some cord signs. So if they've got an atlas that's moved forward on the axis, then there's less room for the spinal cord, so you may be getting some cord signs. Okay? Yeah? Okay? And so the safest thing to do is to do the relocation test. Push C2 forward on C1 and relocate it. And ideally, when you do that test, you should feel no movement. Does that make sense? That means it's already located.
C1 on C2.
Then you can push C2. Hang on, hang on.
Yeah, it's
Push C2, yeah.
So I can push C2 forward on C1.
Fixing your head.
Yeah, fixing the head. So try to fix C1 and fix the head. Then move C2 forward, and that's a relocation test. If you get a clunk or a reduction of symptoms, that's a positive test, and it's not good. Okay? You can then do, so that's the sharp pressure test. Okay. You can also then do the tectorial membrane test, the tectorial membrane stress test, which is doing the other thing, is taking the dent away from the atlas. And if you kind of got, there's a lot of movement there, or if that creates symptoms or problems, that's a positive test. Does that make sense? Mm-hmm. So that's what you've got to sort of try and bear in mind what you're doing. And basically you're either moving C1 on C2 or C2 on C1. Okay, so we're going to try and do that now. Okay. So, I will just bring my skeleton with me. And I'll get my model to jump on the bed. Okay, so with the patient in this position, okay, and you can see the alignment of C1 and C2, okay. If we push C2 forwards onto C1, ideally we should get no movement, because the dent is already located. So a positive test is if you kind of go clunk and reposition it, and there's something like a reduction of symptoms. Okay, and that is, if you have any concerns, that's the place to start. Okay, because you're doing a relocation test. That's good. Okay, so basically what you can do is you can stabilize the head in C1 and basically push C2 forward.
So we think the problem is that C2 is moved.
Yeah, so you might have an unstable segment
Yeah.
between the atlas and
C1
the axis. Yeah.
So C2 is slipped.
Yes.
You'd be in that
Okay.
position.
I don't know on
So that's one thing you can do. The stress test is where you push, well actually you're not pushing C2 backwards in C1, what you'll be doing is lifting C1 forward on C2. That's the way to do it.
C1 on C2.
So you can stabilise C2 and you can push C1 forward.
Yeah,
That make sense?
yeah.
To do that,
You might, when you might not. That is a test that I would be prepared to do. It would be, it's a test I would be prepared to do, but I wouldn't start with it first. I'd test the tectorial membrane, I'd test the alar ligaments, I'd do the reposition, I'd do the sharp cursor test first. And then I might, in that scenario, then sort of check the alar ligament.
Will you do VBI and stuff?
Not necessarily.
No.
I mean, if one of the problems, of course, is that you can, because of relocation, and if there's a slight sort of, because you do know that the VBI has to sort of travel backwards and forwards sort of through this sort of second, sort of quite sort of circuitous, tortuous route. So you may have a patient who gets VBI symptoms. You're going to do VBI testing first. You could do VBI testing, but probably what you may find is that you get, with a test like this, instability, you may get a relief of VBI symptoms as well. Does that make sense?
Yeah, it's quite a grey area.
Yeah, it's a very grey area. It's all very hypothetical. Okay, there's very little research underpinning these, so it's a very hypothetical, mechanically based sort of position. And you're also, I mean, you are looking at matching it up with sort of other sort of signs and symptoms. So you really would be looking for cord signs, VBI things, a history of trauma, or some kind of predisposing congenital features like, you know, Kupfel, Down syndrome, things like that. Yeah? Connective tissue disorders. Okay, so you might have somebody who's got congenital problems, congenital instability, and you may get somebody who's acquired instability through trauma, fractures, joint leg, whatever. Yeah. So that's the testing. To put it into practice, okay, so what did we say? We said that the relocation test, we're moving C2 forward and C1?
Yep.
Okay, so what we'll do is we'll find the C2 spinous process. C2 spinous process. I'm going to basically put my fingers on the arch of C2. Okay? So I'm creating a hand. Okay? So I'm going to put my fingers on the arch of C2 there. So I've got the C2 spinous process between my fingertips, and I've got the articular so I can lift. You can see I'm lifting. Okay? And then I'm going to stabilize the chin. So that's me stabilizing the head and C1. And then what I'm going to do is I'm just going to lift, I'm trying to lift C2 into C1.
You're lifting through your fingers.
What I'm trying to do is this.
Yeah.
Okay? And that's firm. No clunking. That's good. You didn't any clunking, did you? That should just feel solid, firm. Okay? And then the reverse, I'm going to put my fingers around C1. I'm going to, behind the angle of the mandible, okay, so there's the angle of the mandible. To get in there, what I should be able to do is to get the transverse process of C2. Can you feel I'm bony there? Okay, so that's the transverse process. And I'm going to do the same on the other side with my thumbs.
Yeah.
Okay, so now I am stabilizing C1 with my fingers. And what I'm going to do is I'm just going to push down to there. So I'm doing that. I'm just trying to push C2 down with my thumbs on a stable platform with these fingers. And that should feel solid. And it does. Yeah? It is solid. Good, that's good news. Good news. Okay.
So it's already C2 that you're actually pushing with them, isn't it?
Yes, I suppose that's true. Yes. Yeah. Basically, you're doing. If this is C1 and this is C2. For C2, the vocative test is to push down on it. Okay. And for the non-provocative test is to relocate it by lifting it. You can't lift it. Oh, you can lift it. You can lift it. Yeah. You can just get fingers under it. Okay. Yeah. And then the alar ligament. Okay. Basically, what I'm going to do is I'm just going to support C2 best I can in this position. Okay. I'm doing that. Okay. I'm trying to get around the arch of C2. There you go. Yes, I'm so just supporting that. Okay. And then what I'm going to do now is I'm just going to side flex. Okay. You have to be careful not to rotate and go, shit.
I'm just immediately that.
Okay, so you've got to be really controlled about this. So don't grab the head here, okay, because that'll make you want to rotate. Okay, get right back here, so that you're kind of in line with the whole spinal column. Okay, so your forces are there, and what you're trying to do is side flex there, nice and firm. Side flex there, nice and firm. Now there should be a little bit of give.
Yeah, you're giving pressure on the sides.
Yeah? Hopefully it's comfortable pressure.
Yeah, no, that's fine.
Okay.
It's fine.
Okay. So there should be a hard end feel to that. Okay? You happy with that?
So what's a positive test for that? And just if there's no hard end for it.
No hard end feel, so an empty end feel. You probably find there's a lot of range of motion and an empty end feel. Okay? Can I go on?
Yeah, can I still cheat with the more unsafe one? Your fingers to one side too, and then your fingers come across here on C1. Visualise seeing my fingers down and my thumbs out.
Yeah.
So when you're coming to the front, are you on?
So the unsafe one.
Yeah, the unsafe one. Yeah.
So I'm stabilizing C1. We're on
Move down to
C2.
C1 now.
I'm doing that. You can do two things. You can switch down to C2 and you can move C1.
Pushing down on C2
With thumbs, and then
with thumbs.
with C1.
And then for the proper one that we like, the safer one, the relocation, the fingers come up.
Yes, I would like it if you did use
Sorry.
not safe and unsafe tests.
Dodgy one.
Okay.
Dodgy one and the safe
Dodgy
one, yeah.
test is.
Probably won't say that in front of the patient.
No, you're
Do a
fine.
safe one.
Yeah. So the relocation test is this way.
Yeah, so
Okay.
Yeah.
So try
And the stress test is this way.
And then your knees are up there, aren't they?
do the relocation one again.
The relocation one is this.
It's stabilising the head and
Stabilising.
and you're pulling up.
Yeah, stabilizing the head with that.
Yeah, that's
And
it.
then pulling it there.
Yep,
Okay.
yep, got that one.
And then the reverse is that.
Down, and you're holding your fingers on C1. Got it.
And that's when you come off the angle of the mandible,
Yeah,
and find the bone bit.
What do you do APs or PAs? What do you do?
Mainly.
Okay, we'll start with PAs then. Okay. We'll do some PAs and we'll do some APs. Okay? Yeah. Manager, how would it be if you took your shirt off? Would that be okay?
Yeah.
Okay. So your shirt just keeps falls forward into your hair. Okay, so there's several things to consider. Okay, the first thing is the position that the neck sort of drops into. You can see that naturally that happens, can't you? So that's something just to sort of consider. The other thing to think about is that the muscles in this situation can become sort of quite tight. Now from a mood, that doesn't seem to be too much of a problem. It's maybe a little bit tight through there, okay? But remember that trapezius and levator scapula are attached to the head. Okay? So they're tight very high, and so palpating through them, if they're under tension, can give you a sense of hypomobility. Okay? So one of the things we want to think about is, does that just need to be softened off a little bit? Okay? So just have a little, the two of you, what I want you to do is just feel what that feels like through here, okay? And kind of through here, just see it twin. It's not too bad up there, but it's just this, Okay, so just feel that. The tone and the elasticity of it.
Just about pressure, you guys.
My mood, is she hurting you?
No, she's perfect.
Okay. You feel that?
Yeah.
Alright. So what we're just going to do is just try and put the scapula in a more neutral position. Okay. So can you just lift the shoulder? And then just relax. Okay. We'll just do the same on this side. And just relax again. How does that feel? Does that feel better, the same, or worse in terms of comfort?
That's much better.
Feel the difference?
That feels more relaxed.
Yeah? Considerably more relaxed in my opinion, but okay. So that's a big difference. And it can make a big difference to how PIVMs feel in general. Okay? And bearing in mind, if you're a female and you've got a big bust, you get more protraction. Okay? And so you may need more pillows just to try and ease off the load. Does that make sense? And that can make a big difference to what you ultimately go on and feel. Okay. So it is very hard to get onto C01, and the only way you can really do it is by flexing, just flex, there, flexing the head, C2. And it's still very hard to get in there, but that's about as close as you can get to C01. It's the only way that you can really do it. Okay? Okay. And there as well. Okay. And then you can just relax the head off again. Okay. Now, there's a couple of things that we just need to consider. Okay. I was taught this. Does that hurt you?
A little bit painful.
Okay. I can feel it hurts him. I can feel him flinching. Okay. Okay. That's what I was taught. And I can feel him flinching. I can see him flinching. Okay? So, what have we got? Hypomobility? Pain provocation? Or crap hands? Crap hands?
Yeah.
Yeah. Okay. So I'm going to just try and get you to think about doing something different. Okay. What we want is not that. You turn your hands into a nail. His back will act like a wall. Does that make sense? Okay, and it'll be hypermobile. Okay? So what we want to try and do is just soften that off. Now, I try not to push through my hands. Okay? I try and pick up all of that. Okay? So I've got a really broad hand contact. Now I'm kind of halfway wrapped around his head. So I'm kind of on his mandible. Okay? But what I can do from there, you see, is I can... You see how much movement I'm able to create through there? Is that okay for you, Mahmood? Okay? But if I turn it back into a nail... Okay, he's going with me.
The other one looked like you were flexing, extending the lower part of the neck.
Yeah.
Sorry, just think.
But that's okay. That's fine. Yeah. So you're right. I mean, there is an argument. Some people will sort of say, well, that's not an EP. But actually, it's a more comfortable technique for assessing general accessory movements. So you're quite right. Although I'm doing this, you're right. It's fair. I mean, look at this thoracic spine. It's glowing like somewhat, isn't it? Okay. So we can't say that it's isolated. But what I can feel is the sense of accessory motion that is happening and occurring through his neck at the level where my thumbs are. Does that make sense? Yeah. So everything's going like a trampoline, okay? But here I'm palpating what's occurring. I'm not pushing through my thumbs. What I'm doing is I'm feeling through my thumbs. And memory is so helpful. Okay? So can you see how easy that is? Mahmood, can you feel how easy that is for your neck?
Yeah.
Okay. Okay.
So
And this-
is this, which grade is this for you? Or still
Well,
assessing?
I'm not going into resistance. I try and stay short of
So
resistance.
still with 2, 2 plus 3.
Yeah, why do I stay short of resistance? Subnociceptive. Okay, if you want to do a kind examination, do it subnociceptively. If you want to stir up your patient, turn your thumbs back into nails, okay, and you go, does that hurt? Does that hurt? Does that hurt? Does that hurt? Yes, 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 yes. That's what my assessments used to be like. That's what I was taught. Okay? But you can get a really good feel for movement here and kind of go, oh, my mood, I think that's sore, that is it? Oh, that feels okay. And he's going, what good hands she's got. Yeah? So around the side, what I'm going to do is I'm just going to pick up the soft tissue just a little bit. I'm not trying to be sort of unpleasant, but what I'm trying to do is get close to the articular pillar. Okay? So I don't have to go very far to kind of go where I'm on bone. Now I am pushing with my thumbs at the moment because I'm going like, well, there's the articular pillar there. But then I'm going to pick up the soft tissue and his chin a little bit, and I'm going to... Now what I'm not doing is I'm not forcing it. So I think I'm short of resistance. But what I can feel is his neck moving. So can you see what I'm doing with my elbows? I'm not doing this, beep, 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 beep with my thumbs. Look what I'm doing with my arms. And I'm not working. He doesn't want to go with me, so I'm just going to work through it. I'm going to just do what his neck will let me do, and now we're off. Okay? Use the same principle with treatments. Don't try and force anything. Just try and work with the resistance that they offer, and try and, let's just work our way through that quite happily. Okay? So what we're really interested in is, Sionnadh 1. Just tuck your chin in again. And then let go. Just completely relax. That's it. So you're right, what I'm going to get is I'm going to get upper cervical flexion and extension here. But what I'm doing is getting a sense of what the accessory movement is like. Okay? So although there might be some physiological motion going on, what I'm doing is getting a sense of accessory too. But what I'm trying to do is stay subnociceptive, stay well short of resistance, and see what the difference of feel I get is. Want to try that? Centrals, unilaterals, both sides. Okay? So I've got broad hands, good firm sort of contact.
Give you a rest.
Okay. So, what do you think of that technique? What do you think?
Better.
Yeah?
Yeah.
Okay.
I think better.
Yeah. I think if you're thinking of things from a very neurophysiological perspective, okay, obviously in terms of mechanics, that whole argument about am I gliding, sliding, blah 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 blah, okay, is a lot of remote arguments. But if you're thinking about, do you remember my pain map? Okay, and we're thinking about what it is that sensitizes the nervous system. What are some of the drivers of central sensitization? There's only extra bit.
Are you asking?
I'm asking, what are some of the drivers of central sensitization for a patient?
You mean threats and stress?
Threats and stresses. Okay, so painful handling, is that a threat and stress? Okay, right. What else?
Pain.
Yeah.
Pain itself. Okay, so the threat and the stress can central sensitize through descending mechanism. Pain itself, okay, if you do assessments that are pain provocative, that can drive central sensitization. So ideally, I suppose what I'm suggesting is that if we could ideally have a way of assessing the neck that wasn't pain provocative, that would be a good idea. Okay? So I mean, there'll be plenty of patients where you'll be able to get away with doing painful assessment, because they won't be that irritable and they won't be that worried. But for those patients who are, I mean, it's generally a good idea to have handling techniques that are A, reassuring, B, that are non-threatening, and C, that are non-pain provocative. So that takes you away from a whole line of treatment, which is I need to find the pain. Does that make sense? Because if you do your handle, well, you'll still find painful segments, but it won't be that they're all painful segments. Do you know what I mean? You ever seen those patients where you press on everything and it all hurts? What does that tell you? Might be. Clap your hands. Yeah. But what does that tell the patient about you?
Might have very good at what you
Hmm?
do. Might have very good at what you do.
Well, I'd be kind of going,
DNA next to
don't know how long to go back there. Okay?
Yeah.
Yeah. So it's worth thinking about what is the nature of the assessment that you want to do, and does it need to be pain provocative? Now we're going to do other techniques in other areas, neurodynamic tests, and we're going to ask the question about, well, do those need to be painful? Do those need to be accompanying symptoms? You know, I do all of my assessment techniques really, looking for first resistance. I don't usually go through resistance. And you've already seen that I can actually do a lot of movement with, say for example, pavons. A lot more movement than somebody trying to do grade 3s and grade 4s. But I'm exploring movement better than somebody who's doing grade 3s and grade 4s. So I know a lot more about the background motion capacity of the structures underneath. You think? But at the same time, I've done a lot less damage to the nociceptive system. And in actual fact, may be doing quite a lot of good in terms of dampening down the nociceptive system. Particularly if I'm doing my assessment in a way that's non-threatening. Because a lot of people who come in with neck pain and go, oh shit, what is the person? Yeah? And so in those patients particularly, you do have to try and be a little bit careful. But I then can go, well, to be careful with everybody. I can't do it wrong. Okay. Right, so what do we want to do next? We want to do some muscle testing, and I think we should probably do some muscle testing. Do any of you, sorry?
Were you going to do APs as well?
What was I going to do APs? Should I do APs? I might do APs when it comes to the cervical spine. Okay? So I'll do APs then, because I'll come back to C2 then. Is that okay?
As well as, because I mentioned combined movements as well. If you're going to do that for cervical spine.
Yeah, I decided not to do combined movements. Do you know why? Do you want another truth?
Yeah.
You do want another truth?
Go on.
Because I didn't think your handling was very good on conventional physiologicals. Okay? So you have to have good physiological control of physiological movements in order to do combined movements. Is that okay to tell you that? Okay. You did ask.
Yeah.
I was going to just keep that to myself. Well, we can do some combined movements a bit later on if you like.
We'll give them practice.
It isn't, yeah, come on back. If we get control of that, we get control of those sort of physiologicals around the upper cervical spine, and we'll have a look at upper cervical combined movements. Okay.
Yeah.
We'll do APs of the cervical spine on the cervical spine, because that'll be the first of the next block. But I think we should do some muscle testing. Do you do decline flexor assessment?
Yeah,
Something you used to do 10 years ago? Nobody doing it?
What's that?
Deep neck flexor capacity testing.
Do you mean like biofeedback?
Yeah, the bio, yes.
I don't use biofeed.
Okay, you don't have to use pressure
I'll
biofeedback.
pay.
Yeah. So you're doing
whilst they're doing it.
you're doing a bit of it.
Yeah.
You don't sound very confident with it.
No.
Okay. Right. So I mean, one of the things that we saw, and I think it was you, Maddie, when we were looking at right rotation, left rotation, and we were looking at compensatory movements, and and actually one or two others were doing that kind of thing, sort of bowing out of pure movements, and doing that kind of stuff. And the compensatory movement, you were talking about Sam.
Yes.
And you know, when you see that kind of movement pattern, it's actually worth thinking about doing deep neck flexor assessment. In theory, the theoretical argument goes is that anybody who has got headaches, upper cervical spine headaches, will have a deep neck flexor dysfunction. They will have a deep neck flexor dysfunction. Okay? And then the question is, to what extent do you want to measure the capacity that they have? So we'll do some deep neck flexor capacity testing. Okay? But the first thing that we have to do is see whether they've got deep neck flexor capacity or control in the first place. Never mind. Do you use deep neck flexor indexes? No? Okay. So we can think about doing that. We can think about doing it today, and we can think about doing it next block as well. So the first thing we really want to do is to make sure, just to see whether a person's got the ability to do the movement that you actually want to produce. And the movement is very simple. It's just, okay, it's really, can they say yes? Okay? Would you like a gym?
Good luck.
But it's that kind of thing. Do you want a cup of tea? Yeah. Okay? You can overcomplicate it, but it's just a simple yes movement. Okay? Now the thing is can they do that? Okay, so that's the first thing. So can we borrow you with your neck? Okay. Yeah, you can do this in sitting or you can do this standing, you know, whatever you want to do. We are eventually going to do this in lying. Okay? But what we want to know is, well, what is her ability to control her neck? Okay? So, you know, one of the things that we can do is when we were looking much earlier on, we were looking at her extension. And we were saying one of the things somebody might do is that.
Yeah.
Well, you might want to just correct that immediately. There and then sort of see, well, can they do that? Is that something that they can do? So can we just look at your extension? Okay. So that's somebody I would kind of go, oh, good. Okay, and yeah, go back and then come back up again. Okay, and go back. And come back up again. So you can see why I'm sort of thinking, I mean, it's fluent, but it's caved in sort of in the mid-cervical area. Okay? And so what I'm quite interested in is, you know, whether somebody can actually do that in a much more controlled way. So what I'm interested in is, can they do upper cervical extension, middle cervical extension, lower middle, lower. Okay? Because you should be able to get cervical extension all the way down your thoracic spine, so that sort of T3, T4. That make sense? So when you do extension, it should sort of curve down to about there. Okay. So what I'm going to ask her to do is, I'm just going to ask her, can you lift your chin? No? Okay, and then come back up again. You see she's beginning to cave into here. Okay? And what I want her to be able to do is this. Is just to be able to do it without the rest of the neck doing that. Okay? So I want her to be able to do that. And then I want you to be able to do that. And then that. And then that. Until it goes all the way down your thoracic spine. Does that make sense? Yeah. Okay. So can you just do the top part of your neck? Okay. Is your father a giraffe? Oh, so you don't have giraffe in the family then? You guys got quite a long nose.
I've got Scottish in the family.
Oh, you're so lucky. Okay, so we're just going to have a look at that a little bit further. Okay. So what we want to know is, I'm just going to give her a C2. Now I'm just going to ask her, I'm going to just ask her not to move that bit. Okay? So just keep that bit still. So you're going to keep that bit between my fingers there. Now can you lift your head? Okay, she's trying to get out. Can you see that?
She's trying to come forward.
She's trying to come forward, isn't she? Right, so I'm going to give her just a little bit more feedback there. Is that comfortable? Okay, and now can you lift your head?
That's better.
Yeah,
Loads better.
Okay, and then can you bring it back down again? Okay, so she can get it. Okay, she just needs a lot of biofeedback. I'm sorry, I'm not including your circulation, am I? You feel like pulse into both. It's not good. Okay. And again. Good. And then come back again.
Have you just got your fingers in contact, or are you going to give it a posterior pressure?
What am I doing? Am I giving you posterior pressure?
Not much.
No, not really. It's just there.
Controlling.
Yeah.
Okay, and again. So she likes anterior. I don't
Yeah.
don't need
Yeah.
this. Get rid of that. Okay. And again.
That's actually
Oh, I can keep
good, isn't it?
it's kind
You
of
just need to keep following around all
Okay.
day.
Again. Now that's hard, eh?
That's hard.
Wow.
That one to really think about that.
Okay. Right. So that's not great control, but she knows what we're after. Okay. Can you do that, the first bit without my hand there, Tom?
I don't think I can.
Okay, so we might work at that a little bit. So, if you were kind of thinking about, well, we're trying to get control and movement, we might just start with, well, that's fine. I mean, I'm kind of doing that and I'm kind of thinking, oh, that's too easy. I must find something harder for her to do. But actually, that's not easy for her. Okay? And for a lot of patients who've been neck pain, for a lot of patients who have TMJ problems, upper cervical spine problems, headaches, they find that really difficult. Because they've got no idea. You know, Phil was saying yesterday, the proprioceptive morons. I think, did he use that term?
I think
I'm
perhaps
sure he
sharp,
did. I'm
please.
sure I got that from him.
I'm pretty sure I didn't say
I quite like that.
it.
You know, I heard that before. Proprioceptive morons.
I don't know if people get away with it, and I don't.
No, don't write it down. Okay? You're quite right. I can see that you've kind of got a good sense of judgment. Okay, don't anybody else write that. Right. So I might just work at something like that as part of a rehabilitation sort of construct, really. And obviously that's working on extension, control of extension. But of course, control of extension is important for some people. Okay. So one of the things that we might also think about is control of flexion. Okay. So one of the things we might think about is from this position. Okay. I'm just going to give you your C2 again. Would you like a cup of tea? Is that how you say yes? Okay. Okay. So really what I'm trying to get you to do is I'm trying to get you to do this.
Oh, okay.
Okay?
Even if you don't want to.
Yeah.
As you sit there, can you do that?
It's just when she comes back,
It's all I see it, isn't it? She's so overactive there, isn't she?
Yeah.
That's just
it's when it's
so.
the flexion
You get
of the
it?
active, that's when she comes back.
Not really, no.
There's something not right about it. Okay? You can look at that and kind of go, it's not this. Okay? It's not a natural, easy, that looks quite hard.
Not saying yes enough. It just goes rather than.
How are you with this? Perfect. Right. Okay, so I'm going to give you your C2 again, okay? And I want you to just think about lifting and lowering the chin. Good.
It's better.
How does that feel for you? Does that feel easy or hard?
I'm having to think about it, but easier than before.
Okay, so I'm just giving you a bit of biofeedback here. Okay, I know that if I test her deep neck flexors, this is not brilliant. Okay, so what I'm looking for is somebody who can actually do this. Okay, so at the moment, if I had to sort of score her, I'd give her a 0. Okay, just because once we get her in the testing position, we might not be able to do that well. But what we might be able to do is just go quite quickly within session, kind of go, okay, you've got that. Okay, we'll lie down, can you do it lying, and then we'll do business. Does that make sense? So we're just going to see if we can find it. Okay, so off you go again. Nodding. And sometimes it's easier to go up to come down. You have more extension range than you have flexion range. Okay? So sometimes it's easier for patients to start going up than it is to go down. Now, can you keep that going? I'm going to just take my hand away. Just begin to.
Just looks really laboured.
Sort of more protraction.
She's just losing that now, isn't she?
She's going lower.
Just really think about it.
Yeah, you're losing that again. So we can, so we could try her in line and see what she's like. She might be better in line, she might not be. Try it, okay? Sometimes it's easier because you're sort of unloading a lot of muscles and different structures, so you can, you never know. We need somebody who can test them. Okay, so ideally what you want is somebody who can go, yeah, I've got that. Yeah, 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 yeah. And then your business in terms of lying down. Okay, so let's just try lying down. So, I mean, to be honest, we know that we've got some sort of neck problems, but that what I've already just been doing is already beginning to sort of think about intervention. You see what I mean? Okay. So, the nice thing about that kind of thing, that kind of sort of testing, is that that goes almost straight into the kind of home exercise program that you might want to do with somebody like that. Of course, the thing about doing something like that, you have to explain what you're doing and why you're doing it. Because it's a bit, why am I doing this? And my office makes me think I'm mad. Okay? So there needs to be some, it does need a bit of explaining to sort of think about, well, why would you do that? Actually, give me some good reasons for doing that kind of treatment technique.
You can do it throughout the day.
Easy, generally speaking, it's theoretically it's easy to do, although it's not that easy to do.
Time-wise over the day, you can just do it once you sat down.
Yeah, you can do it when you're standing, when you sit down, you can get it right. Yeah.
Need self-management,
Self-management,
functional.
functional.
Control. Just again, control.
Yeah, your control. It's large amplitude, self-nociceptive. And how does that help? Huh? Okay, so you can, at the same time as you are trying to restore control, you are also mobilizing articular structures, in particular C01, which is actually a very hard joint to get in and mobilize. This is probably one of the only ways you can get in and mobilize C01. Reflection, extension, nodding in the head. Just about the only way. There's very few treatment techniques apart from the nip that you can do to C01. You can do retractions. And that encourages a bit of flexion extension. Okay. But it's a really good way to mobilize that articular structure. And you're mobilizing the articular structure, doing stuff with muscles, firing up A beta activity, pain gating. You're also doing stuff at a peripheral sensitization level. So you're doing stuff to tissues directly that are affected. So perhaps reducing peripheral sensitization, perhaps increasing A beta drive, all at the same time as you are mobilizing joint structures and trying to improve control. Fantastic, isn't it? It's a fantastic what you're doing with such a simple exercise as that. Okay? It's amazing, all the underlying stuff that you can do. So easy. You can do it for yourself. Okay. So one of the things we want to have a look at is whether she can do this now. Did you have any positive dural signs?
Yeah.
Okay. You see what I did there? Okay. So and I've got hands crossed here. So I'm just sort of trying to shorten the dural sort of structures. That will make it easier for her to flex. If that's all lengthened out, which could her arms down by herself, that'll tension up the dural structures and make it actually harder for her to flex. So by doing this, we're also slackening off thoracolumbar fascia, which is all connected to the head in the end. Okay. We're just trying to make it just a bit more comfortable. Does that feel comfortable for you? Okay. So in that position, can you do nothing? You can see. Okay. All of that. Okay. So that's going to make it very hard for her. Okay. I'm just going to make it a little bit easier for you, I think. I'm going to try and just put your hand. Okay. There you go. Does that feel more or less comfortable? Feels more comfortable. that makes everything just a little bit slacker around your neck. Okay? I just moved further up. I've moved your more poking. Yeah. It's you know, people have got poking sort of posture, then just a bit more behind their heads. Okay. And being really flat just tightens everything up and lengthens it. So just bringing the head forward a little bit. It may not be kind of neutral in terms of ear and shoulder and stuff like that, but it just makes life a lot easier for patients. Okay. So what we're going to get you to do is the same yes movement. You're going to go up to come down. Okay? Fine, and go up again. Yeah, that's a lot easier for her. Now, what she shouldn't be doing, what you shouldn't see is your sternocleidomastoid all tensioning up, and you can just check that. Okay, just keep going. Keep your shoulder to stop. Okay. Okay. The hyoids, one should be easy and relaxed. So she should be contracting with infant suprahyoids. Okay. You just feel it stiffening up at the end. Don't go so far down, just do it easy. It should feel really easy.
Would you just get the patient to do it as feedback?
Yep. So that's all okay.
No, sorry. She looks like she's almost pushing her chin quite high up to the ceiling on
That's
the way
fine.
back.
Yeah, that's fine.
So that doesn't look so, because that almost looks like it's going into that transition position.
It's okay to, because what she's doing is sliding the occiput. The good thing about having her
She's
occiput,
extending.
yeah, the good thing about having the occiput on the pillow is it actually it gives her proprioceptive feedback. Okay, but because she's leaving her head on the pillow, it's unlikely that she's protracting. Okay, what she should be doing is lifting her chin, and the occiput should be sliding underneath. So she should feel her head sliding on the pillow. Okay. Yeah, good. Now what you don't want is retraction, so you don't want her doing that particularly. But we're working towards control of cervical curves. Okay, so don't push down here. Perfect. Okay, that's good. And then the next thing, you can have a relax there. The next thing that you want, now that you can, I'm quite happy with that, your ability to do that. Okay. So there's not too much sternocleidomastoid activity. And what we really want her to be able to do is to drop her neck there and hold it for kind of 10 seconds. And then come back up again and repeat. Okay. She can do that, 10 lots of 10 seconds of hold, then we'll get the PPE out and we'll measure her capacity. Is that good? Okay. So that's what we want her to be able to do. Okay. Right, so off you go again, up, come down. Hold. What patients will tend to do is they'll tend to go like they're leaping over something. Rather than kind of just stopping, they'll go and do a little extra contraction at the end. And that's not what you want. You want that all to be sort of quite relaxed. And that's just taking back on you. Okay? And come back up again and relax there. Can you see feel how loose that is? We want that all to stay loose and relaxed here. Okay? And off we go again. So just stop. Okay? And just tightening up. Okay? And come up again. And just relax there. Just let go of everything. See? Okay? And then come down again. Hold that there. Just tighten up. Okay? And she shouldn't. Okay? So she's not ready to do holding just yet. But what's quite clear is that we've changed her ability to nod. Okay, we're going to sit you up and see if you can do that sitting up now. Now that you've had a whole pile of training, trouble is we've taken away proprioceptive feedback as well. Okay, so you want to put your feet on the floor, would you? Yeah, they're nearly there, aren't they? Okay, so let's have a look. Are you able? The pressure's on now. Not so far up, not so far up. Just come back to neutral, okay? Just a little way up and a little way down. Yes. You see, at the end there, she's just kicking forward, isn't she? Hold it there and down. And again. Hold it there and down. Again. Hold it there and down. Can you see her wanting to do that, can you? Okay. What you're hold it there. What you're trying to do is trying to go up and then you're doing that. Okay? We really don't want that. Okay? Okay. Yeah, looking down and looking up helps. Look up. Fine. Look down. And look. So don't go all the way up. That's fine. And down. Do the same thing. Let's try and do that 10 times. Quite happy with that at the moment. Fantastic mobilisation for Sionnadh though. Fantastic. Don't go too far down either. Are you kind of losing the plot there?
Yeah.
Yeah? Okay. No, that's fine. That's one. So she's just losing the plot there, isn't she? Okay, and just losing control of that. So I wouldn't labor that. I kind of go, right, let's lie down again. Yeah, and let's get it down, let's get this down. Because you want them to be able to do this in sitting. But they can't do it in sitting, they have to go from lying to sitting, lying to sitting, lying to sitting. Okay. This is where you learn what it feels like to do correct.
It's amazing how hard that is. I can't quite believe it.
Okay, so let's go again. So you can yourself just feel that there. Okay, make sure that stays nice and relaxed. So you can relax the arm and the chest there. Make sure it stays soft, relaxed there. Okay, and let's have a look. You do that nodding again. Come up. And down. Down. Come up. Good. Is that that?
I just feel it at the end trying to.
Okay. So stop before you get to that. So we're assessing and we're recapping all at the same time. Okay? Good. Got that? Okay. Right. Try and sitting again. Good. Fine. Fine. And then, not too far down, okay? Are you losing the plot there, or is that?
I think I'm starting to get a bit crooked.
Does it feel different?
Yeah, it feels really loose.
Good. You happy with that over there?
Better.
Yeah, it's not looking too bad, is it? She's learning. She's learning. She's not ready for deep neck flexor capacity assessment yet, but okay. I'd be quite happy with that to sort of say, you know, what you will probably find is that you lose the plot.
Yeah.
You know, and you kind of go, I can't feel my head anymore. I don't know what I'm doing.
Yeah.
Stop at that point. Okay.
Sure.
Lie down and try and lie.
And the reason why you should not go through the capacity test is that because of it's too much work.
It's okay. She couldn't hold it.
Yeah.
Because she can't hold it.
Yeah.
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 You need somebody to be able to do holding
Yeah.
10 seconds
Yeah.
without getting an increase in their superficial cervical flexor activity.
Yeah.
Is it getting an increase in superficial fibre activity? That is not muscle control that you're looking for.
Right. Yeah.
Okay.
Yeah. She
So,
will come to test.
And as soon as you put a PBU behind their neck, they will do more.
Right.
Okay.
Yeah. Yeah.
And that's the problem.
Right.
Okay. So the moment she gets a 0 score,
Mhm.
not for, I mean, she's improved and changed, and you know we've been able to sort of change her quite quickly,
Mhm.
but she's still a 0 score
Mhm.
because we're not able to test her capacity.
Right. Yeah.
Does that make sense?
Mhm.
But that doesn't mean to say that she won't get benefit from from something like that. I mean, you said that feels looser. What we'll probably find is if we go and look at her upper cervical pivens, pavements, things like that, what you probably find is that feels really different. And that's good. Okay? So when you try this in a minute, you assess her neck and you see what's changed in her ranges of motion, upper cervical pivens and pavens, and you tell us all what you find. Okay? But I'd be willing to bet, not a whole month salary, but I'd be willing to bet your salary, that that has changed a lot. Yeah? Does that make sense, what we've just done there? Okay? Now that is a fantastic articular mobilization technique as well. Okay? So yes, I mean, what I'd be saying to you is, you know, when you lose the plot, if you kind of go, I don't know what I'm doing, go back to here as your starting point, and then come up to sitting and do that until you lose the plot. Yeah, yeah. That's you giving yourself your own biofeedback. It does make a big difference. Yeah, and that would be the kind of thing that I would want you to practice at home between now and coming back here as part of your homework. As a way of trying to manage whatever's going on. And of course, depending upon what you find in terms of your re-examining of objective markers, we can talk to her about that and sort of say, that looks like it's going to change this, this, and this. Does that make sense? Okay? So, and that's how I use my objective, that's how I use my manual therapy, to create objective markers to see whether I get within the session changes. And that's what I really want to know is, am I getting any changes with self-management strategies, exercise sort of strategies? Okay? She sits up and kind of goes, oh, that feels better. That's a good sign already. And then if we can reinforce that and sort of say, well, this is also what's changed in your neck. And then we can sort of say, well, what do you think about that exercise? She's already thinking, it'd be a good idea if I did that. Right? It'd be a good idea if No, that's right. And then if we can reinforce that with kind of messages about, well, that changes this joint sign, that changes this neurogenic sign, changes this muscle length test, you know, whatever you're looking at, changes whatever you've got in neurodynamics, if you've been looking at that, and you're kind of going, that looks like a really good way forward. Quite simple, quite straightforward, maybe not that easy, but a good place to start. Reversible. That's all good, eh? Right, do you want to have a go at some of that and see what you like? And we'll see what we've got that's interesting in the room. Okay?
Also,
I'm hoping that you've just got a few minutes to spare. Because we'll just have a bit of feedback from Sam about how Maggie's neck is going. What did you find?
On the three things that I tested, range of movement was the same, and she still does this thing at the end. Lateral flexors at the end both ways, so that hasn't changed much. But the dural test was much better. And when we pivotted her, she had quite a grotty sort of left side, almost sort of 2, 3, 4 area, and that was better.
Okay. So now we're in a position to sort of say, what do you think about that?
I like it.
You like it? Okay. Now, the next thing we're in a position to say is, what do you think you can do about that?
And practice my nodding.
Is that something you feel that you could do at home?
Yeah.
Okay. Okay. So, I mean, that's the kind of conversation I might have with the patients, try and make sure that they kind of see that although she's sort of going subjectively, that feels a lot better, I really kind of hammer up and try and really beef up the positive messages about the reversibility and stuff like that. I'm an adherence researcher, so I'm very interested in the things that help patients to adhere, and these are the things that we can do, I think, that can really help patients to go, do you know what, exercise, movement of my head, movement of my neck, I feel really differently about that now than when I first came in. Does that make sense? So those fears, those concerns, those anxieties, And patients are kind of going, ooh, that's good. Ooh, I like her. Yeah? So, we're doing a lot of different things on a psychogenic front. So can you sort of see how we can use manual therapy with a really psychosocial or psychogenic sort of perspective? So a lot of people think manual therapy is a very mechanical way of treating, but actually we can do a lot to enhance its psychological effect. More for it, me. Okay, does anybody have any questions about what we've done today? We haven't finished what we needed to do. The good thing about the muscle stuff is that it's the same, the muscle stuff is the same for the rest of the neck as well. So we'll continue on with it in the next session. But we'll hopefully got a starting point with some of the things we can think about. Has anybody got any questions about what we've done today? Quite happy? Does that sort of feel quite like you've done something useful? Okay, useful block? Interesting.
The deep mixity is 10 seconds, 10 times. That's what you're aiming for?
Yes.
Right, so that's the 10, say, and maybe it's a 0.
Yes.
Okay.
We'll have to try the next time.
Oh, okay.
We'll continue on with
that stuff. Okay.
I was just sort of saying to some other people, I don't use deep reflex capacity testing a lot, so it's not the most important thing that we can do, but it's a useful outcome measure or a useful objective marker that you can use for some patients some of the time. I try and use it all the time, it's very time consuming, but for some patients it's really useful. But I think there are a lot more functional things that we can do for rehabilitation, and we'll look at those as well next time.
10 times 10 thing, evidence-based.
Yeah, I've given it, I don't know if you've seen it, I know some of you have seen it, I put a handout on Blackboard, I put it on last minute for you. And it's an old handout of mine from when I used to teach that course. And there's some information on there about the push biofeedback and how it's used. So yes, there's some quite sort of old information about it, sort of from Guangzhou and the University of Queensland. And some of it's quite old now, but it's still really relevant.
That Ken Neary podcast when you mentioned 10 by 10 seconds.
Yeah, that stems from them. Yeah. So the original research is 2000, 2001, 2002 from back then, but it's still quite interesting current research. Yeah. So I think I put some reference on the handout. So the handout sort of covers some of the stuff that we've done today and provides some descriptions of some of the stuff that we've done today. Yep.
Sure. In terms of like Maddie's neck then, I mean, like say like using manual therapy in like a psychosocial way. I mean, with someone like with Maddie's neck, I mean, there's no need to use any manual therapy at all. It's pretty just to look at range of movement and then seeing that she's not very good in deep neck flexors and just treated that.
And then not understood what's going on in the arthrogenic structures.
Do we need to know what? I mean, is there anything going on?
Well, I think we need to understand what's going on in the arthrogenic structures, with either to eliminate their involvement or to implicate them.
Yeah.
Okay? So what we do have is we have findings that are at the moment reversible through with exercise, but we haven't eliminated them. There's still some outstanding hypermobility or something
Could that
going on
not
in the
just
neck,
be-
there, isn't there? So there's some improvement, but we just felt it was improved, but it wasn't resolved.
What things do you mean in terms of that?
When we were doing pavements,
Yeah.
what we found was that there was a stiff segment, and the stiffness has improved, but it's not resolved.
Could that not just be normal?
But use of overpressures then, would that not also give an indication to try and test? With the Enfield, with the overpressures,
Yeah.
then go on to do your pavements.
Yeah. Well, so what we're saying is that at the moment, using arthrogenic features, there are still some arthrogenic signs.
We don't think they could just be just normal for her, just directional preference sort of stuff.
Yes, well, it could be. But what we'll do over time is we keep an eye on that, and we think, well, if we do improve that further, either with exercise and the joint signs keep improving, then that's okay. and we don't need to do manual therapy. But if the joint signs begin to just get stuck and not changing, then we do have the option of kind of going in with our manual therapy and seeing whether that improves things further or not. Okay? So at the moment we can look so we can resolve quite a lot of things with exercise, but what we haven't done is kind of gone, we have cured the problem with that amount of exercise. What we've got is a marker. We've got neural markers, we've got arthogenic markers that we can keep an eye on as we do motor control type rehabilitation. And if the joint signs don't continue to improve with exercise, then we can get in there and do some other stuff.
I think I'm just thinking like clinically, in terms of time pressures.
Yeah.
Just
Anything
if
that
I
you
can
can
miss
do.
things out.
Yeah. Well,
This is quite quick, though.
That-
Isn't it? This is only, this 10 seconds, 10 times 10 hours is very old, isn't it? It's not, this isn't new, is it?
that's not new. No.
But it's very quick to implement on patients in a half-hour session, a 20-minute session. You do it quite quick.
Yeah.
You screen the other elements and all
Yeah.
back in.
But I mean, the thing about doing exercise, the thing that's important about exercise is that we don't just prescribe exercise, we understand the effect that exercise
And
has.
you've got to be doing it right as well, aren't you? You don't want to go away doing it.
That's right.
Correct.
Yeah. I mean, the advantage of what we've just seen is that because we've assessed and reassessed following the exercise, we know what we can expect. I'm in a position where I can go to Mary and say, I don't know what you want to do exercise. I'm here going, I feel really confident that there's some really positive things that you can do with your neck. And then when you come out next week, my neck is going to be a lot better than it is today. It may not be perfect, it may not be cured, but we should be able to see a big change in your neck.
But also she hasn't got any neck problems.
Sorry?
She hasn't actually got any neck problems.
She's fine. Have I got something bigger that I can throw at you?
I feel quite privileged if you throw the towel at me.
If she was my patient, and she had a neck problem, you do get some neck problems very occasionally, don't you? She's a bruxer. She didn't tell you that, did she?
She probably spends too much time on a computer, that's probably why she gets too much.
Anyway, that's all I've got for today. I would really appreciate if you just got 2 or 3 minutes just to fill in an evaluation form. We're evaluating every block at the moment because we're running this for the very first time. So I've got 5 questions for you. Each of the questions has a. Okay. We've got a 0 to 10 scale, and you can mark how helpful the stuff that we've been doing is. If you've got further comments to add, please do let us have comments because they really enhance the feedback that we're getting. We do try and take into account what you're saying. Okay? Almost really much from you.
So 0 is rubbish, is it?
0 is rubbish. Okay? And 10 is absolutely excellent. And that's a scale we'll use for you in your exam as well. Don't forget to put your name on it.
Start.